adapt to it.
Listening to the outrageous reproductive endocrinology and infertility specialist. And I am here with my dear friend, the quote unquote Dr. Tarek Ibrahim from Ibrahim Strategies Group, my social media guy, who does not have a medical license, but
that's never stopped me from practicing.
We should go live on the other platforms.
Yeah, you are.
Oh, we are?
You are,
We're
yeah.
on Instagram, we're on everything?
You're on everything, yeah.
Excellent. Yeah. So, welcome everybody to the show. Wonderful evening tonight. And I am going to vent. Tonight I'm going to vent. So, I was kind of disappointed recently to see that I was included in one of my colleagues' Instagram posts. And they included me. Oh, that's not good.
Why is that happening today?
Maybe.
Oh yeah. Amateur move.
How's that? So I was quite disappointed to see that my colleague had actually said what we had said was wrong. And this was in reference to the fact that last time on the show, we talked about medicated cycles, and I put out a post, which even on our Instagram was a little bit controversial, saying that most people should not do medicated cycles. And in fact, my words were, no one should do medicated cycles unless they are in menopause.
Hold on. Somehow I got the cameras a little bit wonky here. Just bear with us.
Which cameras are we talking about?
Somehow I'm the main camera right now, which is fine. Hello, everybody. But it wasn't my move. It wasn't my move.
I can go on because everybody else is watching. So here's the issue that we had. And a lot of people that were asking were on TikTok last time. So the data that my colleague referenced is from 2020. And she references a Cochrane meta-analysis, which only looked at randomized controlled trials. And unfortunately, every single study was ranked as either low or very low evidence, quality evidence. And so I was like, why are you referencing a 2020 study? That study actually has been superseded by a 2025 study, so I couldn't even understand why she was referencing the first one. But more importantly, there are better studies done with a lot more data included, including the randomized controlled trials, as well as the cohort studies. Now, there is a big difference between cohort studies and randomized controlled trials, but the RCTs were all poor quality evidence. So they're not great studies in and of themselves. So the bottom line with all this is when you look at the overwhelming burden of data, it's pretty clear that the majority of meta-analyses, systematic reviews, and as well all of the data points from even individual studies actually show that the data favors doing a natural or modified natural cycle over a medicated cycle. Specifics, I'll give you a couple. So number one, 26 randomized controlled trials and 113 cohort studies. So this is not a small amount of data. This is a huge study, okay? Big network meta-analysis. The outcome, patients that did natural cycles instead of medicated had a much higher live birth rate. It was a 19% decrease if you did a medicated cycle compared to a natural or modified natural cycle. That is huge. In the IVF world, 19% is like everything. That could mean you doing another cycle. A more recent randomized controlled trial published in PLOS, huge journal, very important, very, very famous journal. This was an open label randomized controlled trial because, of course, you knew which meds you were on. And they showed an 11.1% decrease in live birth in the natural versus the medicated. So the medicated group had an 11.1% decrease in success. There's other studies as well. There's one from AJOG from 2023, which summarizes the entire article saying that it's not only a higher success rate and a lower miscarriage rate, but that it's also safer. And that's the part she missed when she was talking about the medicated versus the natural cycle. We can sit here and debate the quality of the data, and we can go over all of that. But meta-analysis in Human Reproduction Update clearly demonstrated enormous increases in the risks associated from a pregnancy standpoint for patients that do medicated cycles versus natural. I'm going to read some of these to you because I think they're important for everybody to hear, okay? So follow with me here. comparing a natural cycle to a medicated cycle, lower risk of large for gestational age, 12% lower, macrosomia, 19% lower. Those are really giant babies. Low birth weight, 19% lower. Early pregnancy loss, this is miscarriage. You finally got pregnant with your IVF, your embryo transfer worked, you did a medicated, 27% higher risk of miscarriage. That's huge. I mean, that's devastating for these patients going through it. Preterm birth, 20%. Very preterm birth, so these are the really small babies where it's an unholy disaster. 34% reduction if you did a natural versus a medicated cycle. When they looked at hypertension and hypertensive disorders of pregnancy, 40% decrease. Preeclampsia, 50%. You cut your chances of developing preeclampsia in half when you do a natural cycle versus a medicated cycle. And this is important because IVF patients are inherently at higher risk of having complications from pregnancy, including preeclampsia, which is huge. Placenta previa, 16% reduced. And the most devastating one for a lot of women, which can be truly life-threatening, postpartum hemorrhage, a massive 57% decrease in chances of having a postpartum hemorrhage when you had a natural versus a medicated cycle. So I'm all for debate. I totally respect my colleague. I actually really think she's got great content, and she just put out this famous book and she's doing really great. And I think that's wonderful. And I got nothing against her. But in this particular instance, I did find it kind of puzzling, and I needed to vent because when I present the data, I'm presenting what I know to be true based on extensive review of the evidence, confirming that it's right, double checking that it's right, and knowing the studies inside out and backwards. I'm not referencing a 6-year-old study that was superseded by one 5 years later. And I'm also going to mention the quality of the studies and the data and the quality of the analysis. So these are really important things. Moreover, I'm going to look at the whole subject, which includes, in this case, pregnancy outcomes, which she didn't even mention. So, summary of all this, should some women do a medicated cycle? Yes, of course. There are people that are menopausal, they have to. There are women that don't succeed with natural cycles because their body just doesn't respond. Okay. There are some women that can't take certain medications and they're going to need to do a medicated cycle as well. Absolutely. There are going to be opportunities for that. And I want to apologize if I was too kind of all-encompassing with this big statement before. But in the overall patient population, you are going to have a higher live birth rate. You're going to have a higher clinical pregnancy rate. You are going to have a lower miscarriage rate. And you are going to have way, way lower complication rates of virtually all of the dangerous, concerning things that we face in pregnancy. Now, most of my colleagues no longer deliver babies, and maybe they're not aware of that data, so I can't really blame them for not paying attention. But, you know, if you're going to go after someone, you should probably be aware of all the data. So I think it's really important for people to talk to their doctor, come up with a protocol that fits them and suits them, and decide what's right for you. Absolutely. And who's the one that's going to choose ultimately? You, the patient. There's no question. I'm not going to choose for you. You're going to choose for you. But we're also going to guide you through the data and make sure you understand that in the end, a natural cycle is better, and medicated cycles are archaic, should no longer be used. And that's being supported all across the world now, including in Europe, where in a conference with hundreds of people sitting there, one of the European leaders in fertility said, this was a mistake we made from the beginning and never should have been done. And it's absolutely true, because you're overriding the body's natural mechanisms, and that actually is detrimental in that particular instance. So I just needed to vent. I appreciate you guys letting me have that opportunity, because it was kind of off-putting to wake up this morning, start brushing my teeth. I'm flipping through my IG and I'm like, what? This is not what I was expecting to see, especially from someone that I really respect and admire and I've had a cordial relationship with so far. I don't know, maybe they had a bad day or they just decided to jump into this topic without really looking at the data. But the data does support what I said, and I can defend that to the end of my days.
You are
a gentleman
and a
scholar on handling it the way you did. Because
You wouldn't have done
have done
that.
that.
Yeah, I even if they were going to do that, like, give me a heads up, tell me to come on and, give my half or my input or whatever. It wasn't cool the way that was done, and I didn't appreciate
what
it.
I wonder is that once it comes,
because
this is
quite
quite documented at this point
that you
that you were right.
when the
The
evidence,
evidence is given
Yeah.
and the proof is given,
is
is there an apology?
No, and I don't want one. I mean, I'm not looking for an apology. I just wanted to vent because it wasn't what I was hoping for when I woke up this morning, and I was like, what the hell is this?
that does not compliment teeth brushing.
No, and it's one thing if, like, I made a mistake, like, I'll own up to my mistakes, right? I'm happy to accept the fact that I've made a mistake, accept it, admit it, apologize for it, move on. But in this instance, I'm not wrong. The data is overwhelmingly in support of what I said. The data she's using is out of date, and she didn't even comment on the quality of the data she was using, which was miserable. Even in the conclusion of the Cochrane review, it says we cannot say anything about this because the evidence is so poor, we don't know. And there's too many pluses, minuses, and they couldn't make anything out of it. But when you look at other data and other network meta-analyses, they actually do support a benefit. So, am I going to continue telling my patients to strongly favor a natural cycle or a letrozole cycle, which is even better than natural? Absolutely, I am, because it's the right thing to do, and it helps patients the right way, and it gives them the best chance possible. And that's what we're about on this show. Share the data with people, let them decide.
There's an audio problem for fun. Let me just check that one. Hold on.
Oh God, don't tell me we missed everything.
No. They heard you.
What's the audio problem? So we're going to take questions. If anybody wants references from any of the articles that I was chatting about, I'm happy to show them to you. You can go look at any of these. It's pretty easy. I mean, even just the conclusion. In women with a regular menstrual cycle, strategy starting with natural cycle endometrial preparation results in higher live birth rates than endometrial preparation with HRT. It's kind of a no-brainer. And this is a randomized controlled trial from 9th of December, 2025. We're talking 4 months ago. So 5 months ago. It's pretty obvious that the data supports this. And, I just wish people would maybe think before they speak.
Yeah, but then you couldn't sip the tea. You know what I mean? Then you couldn't have this nice moment where you got to just put it all out on the table.
I appreciate the audience letting me vent. Did you fix your audio problem?
I think so. I definitely did something, so that should do it.
Okay.
A question related to what we just discussed. I think that's fair.
Sure.
Right? It's not going to get anybody into any trouble. It's just like, why are so many clinics still doing medicated? Is it for scheduling purposes?
Yes. It's scheduling or ignorance. I mean, the data is overwhelming that it's better. And look at the safety data. Like, it's sad that most fertility specialists don't deliver babies anymore. It's a lifestyle choice. I get it. They all went into infertility to make a lot of money and help people and not have to be awake all night long. For me, I like seeing it through. I want to see it through from the time that I meet the patients and help them get pregnant all the way through to handing them their baby, literally. And I think that's one of the most joyous, rewarding things ever. But more importantly, it gives me a perspective other fertility specialists don't have. I think I know how to manage pregnancy-associated risks and complications better than my fertility colleagues that don't practice obstetrics do, because they're not practicing obstetrics anymore. And I think it makes a night and day difference, which is why I know that data on safety. I know the outcomes. I know how it's going to impact you. And so I think that that's really, really important for people to understand. It's not just about success. It's about safety too. If we get you pregnant and it's not a safe pregnancy, did we hurt you or did we harm you? right? I think we harmed you. And so we have to be responsible for the whole journey. Just getting people knocked up and saying sayonara, that's not cool. Like, that's not the whole picture. You have to take care of them. And I personally feel you're responsible for their outcomes. So if you're not giving people that full disclosure about what the risks are from a medicated cycle, are you really doing them a service? And who in their right mind, who has the choice between a natural and a medicated cycle, is going to choose to use a medicated when you have that many higher risks of complications in pregnancy? Like, I don't know, maybe someone would, but like, how does that make any sense?
It doesn't.
No, it doesn't. The risks are way, way higher.
It is people that are just not being given the full information.
Yeah, or maybe she does and she didn't talk about that. But I mean, present the whole story, because if she did present the whole story, she would have said, by the way, while there's no outcome difference in terms of success, according to her study, there is a huge difference in safety profiles.
You know what? I'm even wondering, like, let's say someone went and they're like, hey, we're going to disagree with Dr. T on this subject. He's completely wrong. Before I respond, and me just being what I would like to call myself a student of knowledge, I would research
the snot out of it.
Yeah, before I respond, I'd be like, hey, did I actually get this wrong? Or like if my instinct is this guy's an idiot, I'd have to be like, well, let's just make sure he is an idiot before I go off on,
right.
You know.
Right. And you can go to any medical, sort of AI app and type in, is a natural cycle preparation for FET higher success and safer than a medicated FET? And they will all tell you the exact same thing. Yes.
Should we do it?
No, I did it.
Should we do it just now for fun online?
Just to do it.
No. Let's just like random chat GPT and ask them that question.
Chat's not a medical thing. You go to Consensus, which I've talked about many times. I have no association with Consensus, but I do love it. It's great to use. And I already checked, because I was like, okay, wait a minute. Like,
maybe I got this wrong.
Right? Like, let me double check my knowledge, because maybe I did make a mistake, right? I'm open to that. I will always double check everything. And it said no. I mean, I can read the summary. It said no. Studies consistently demonstrate that the live birth rate is higher with a natural cycle than a medicated, and is way safer. So, like, I don't know. I mean, there's a phrase I want to use about when you go to take down the king, but I'm not going to use it.
This is where I come in. The unofficial Dr. T.
Unofficial Dr. T.
This is where I can.
You can say
slings, throw mud. I can sling.
Yeah.
So, anyways, thank you for sharing your tea with us.
Thank you. Yeah. Yeah.
The people are happy.
Yeah.
The people are happy. Super duper tea. Fertility results showed urea plasma after treatment. Is it possible to be reinfected from a vibrator that gets washed with soap and water?
Go ahead, T.
I don't even know where that question was going. You know what I mean? My mind went bananas, to be quite honest, when I read that. I was just like, okay, yeah, sure. Because soap, is that always 99.999% bacteria free?
I would imagine that if you really cleaned it properly, it would probably clean the bacteria off. Although I don't honestly know what the bacterial adherence to a non-live surface is. So I don't know what the answer to that question is. It'd be easy to figure out. Wash your vibrator, take a swab, take it into the lab, and ask them to analyze it.
You said that'd be easy. You said that in the same sentence. It'd be really easy for anyone.
It would.
Get a swab, just throw it in some microbiological test.
No, you could.
Of your home.
Whoa. You could. You absolutely could. You could swab your vibrator after you've washed it and see if it's still got urea plasma on it. But at the end of the day, urea plasma is actually very difficult to eradicate. We've gone through a series of antibiotics, finding that doxycycline almost never works in our case. Azithromycin doesn't work very well, which was our second line. And so now we're using levofloxacin as our main agent, because every time we were treating patients with urea plasma with the other agents, it was just coming back all the time.
Based on my understanding, I actually don't think it would go. But that means nothing, in my opinion. Because like you said, it takes so much antibiotics to clean it. I feel soap is just, you got to put what's it called on it? Hand sanitizer.
Hand sanitizer. Yeah,
you got to put that in vodka. You just got to drench that thing.
Don't do that. That'll ruin your vibrator, people. Yeah.
Hi, doctors. What is the research for taking Tacro after getting a positive preg test? What are the pros and cons for staying on it? Thanks. 7 losses. Thanks.
I'm not aware of any data that shows that taking Tacro after you're pregnant is beneficial. There is data that shows that taking Tacro before you're pregnant is beneficial, in particular for patients with high cytokines, endometriosis, but I'm not aware of any data that supports the concept that you should take it after. Now, undoubtedly, there are reproductive immunologists out there who are measuring cytokine levels after you're pregnant and probably starting stuff like Humira or tacrolimus or sirolimus. And I'm not aware of that data. I'd have to go look that up for you, but I've never come across that data before. And we are big believers in starting everything you need before you get pregnant, not after.
There are so many questions on TikTok right now.
Okay.
So we're just going to try and take some. They might be like your 1-word answers. I know you like those.
Go for it.
But here we go. You ready?
I'm ready. Rapid fire.
We're going to try.
Yeah.
I don't know what we're going to achieve here.
I'm good.
48 eggs retrieved yesterday.
You need to do a split screen on YouTube, TikTok. I mean, YouTube, Instagram.
Don't ask me to play with this.
Can you do a split? Do we have a split screen?
Yeah, there is a split screen.
Where's the split screen?
No, we're not going to do that now. We're not going to do a split screen now.
Okay.
Don't make me start tinkering.
All right, go.
We already had audio hiccup.
Okay, go for it.
I'm already, I actually thought we were going to be early and punctual. I had everything queued up. The live was going for 10 minutes, and all of a sudden it's like echo. It's like that guy.
Okay, go.
48 eggs retrieved yesterday, 27 fertilized. Is this bad? Does quality go down with this many eggs?
In our experience, yes. When you get really high levels of estrogen in eggs, you do see a diminishment in the quality, I think. So yeah, in my opinion, you do see a slight decrease. I think the other factor is that I would want to know how many of the eggs were mature. So when you say 48 eggs retrieved, were 48 of them mature or were only 27 mature? Maybe you got 100% fertilization. So I need to know the dynamics behind those numbers, but there's no question that that's still a lot of eggs. You got to see how your embryo development goes in order to figure it out.
That wasn't rapid fire at all. Just to really be honest here. Okay, so look, I thought he was like 100 questions. You decided.
Go.
I'm supposed to do an IVF in July.
Okay.
Just got my AMH and I'm at 0.017.
Okay.
What does that mean for me?
I don't know if that's nanograms or picomoles, but either way, it likely indicates that you are menopausal. And so it would be challenging to get your ovaries to produce the right number of eggs. Not impossible, but very challenging. You will likely also yield only a low number of eggs. And there is growing data, and I'll probably review this on next week's show, demonstrating that if you have low AMH and you have diminished ovarian reserve, you actually have poor outcomes too. Like there's lower rates of genetically normal embryos, even when you control for age.
So I think you're missing the whole point. The whole point.
Yeah, I know.
This is supposed to be rapid fire.
But people want, but they want
I know they want a real answer.
Right.
I know. So I'm going to switch gears, go to a different platform because the time is up. Onto YouTube.
Sorry. Okay.
Guys, what are we going to do here? The Greatest Kings.
Oh, nice.
So let me help the TikTokers because they seem not to be aware of our format here. I know. Look, guys, as it is right now, and this could all change one day. We have so many questions. And I think this is a good disclaimer of things potentially to come.
Yeah.
That we're going to have to figure out some way to prioritize questions because we're just overwhelmed here. I have over 999 plus comments on TikTok alone.
Wow.
So like how do we pick these?
Okay.
We need some sort of picking mechanism, right? On Instagram, same story.
Okay.
So many. So for now, guys, we're just going to pick them in order, but we're working on a theory of how to figure it out. So I'm putting that in its box for now. However, the Greatest Kings. That's us.
Okay.
My transfer was yesterday. Embryo was 3AA. Upon thaw, it was 1AA, non-expanded. Should
Okay.
I be worried for it? Will it expand in my uterus?
Most embryos do. But unfortunately, there are studies that show that your outcome is directly related to the diameter of the expansion of the embryo when they transfer. So hopefully it will expand. I ask this question from my embryologist all the time when we get an embryo that hasn't expanded. And they say, no, they're happy with the way it was growing, so they expect it to expand. But not all of them do. So that's a tough one.
I have a long one here, Dr. V.
Okay.
It's like actually long. I have to like really pay attention here. Doesn't even start good, to be honest.
Okay.
Hi, Dr. Victory.
Okay.
Half marks. Thank you for what you do, but I just want to reach out to you. Recently, I got really hard to reach the stuff at the clinic. I called yesterday to report my cycle day 1 for my upcoming SIS and other tests before transfer, but no one got back to me. We have found similar issues that we discussed in a group created just by your patients. The communication's been really hard compared to the earlier years when it was phenomenal.
Okay.
Any thanks to you would be less because of what you do for us. But again, we would appreciate if we can get that level of care that we used to get, and any communication would be taken in notes sincerely, because it means a lot to us and we look forward to you for building families. And thanks a lot. I am a mama because of you.
Oh, well, first of all, I'm sorry you and anyone else is experiencing that. We have multiple receptionists and they are answering calls and they do return messages, and we have a whole team of nurses. So I'm quite puzzled. If you could DM me and I will give me the names and the lists of everybody that's had trouble, and I will definitely take it to the management and make sure that they are doing a good job with that. That is not typical. So I will definitely address that with everybody.
There are so many people that just keep asking the same ones over and over again. Oh, these are questions on TikTok. Yeah, we know. Believe me, we know. And we see who you are, guys. We know who's doing that. So not to worry. We know. Hi, gentlemen. What happens if results are poo after a triple stim and want to try again? Do you have a quadruple stim package?
Oh, no, but we just keep adding on an extra package. There is a package for the add-on package.
Dear legends, this is where the respect comes in. You know what I mean? Would you recommend against traveling for a work trip during the 2-week wait from the US to the UK?
No, not necessarily. I mean, we have patients coming here from the UK in order to get pregnant, and they're going to fly back like the next day. So no, I don't have a problem with the work trip. Get up and walk around in the plane. Make sure you eat healthy. Probably wear a mask in the airport. But no, I don't have any issues with it.
May I add?
Okay. Yeah.
So I like Dr. Victory. Agree with his opinion.
Okay.
However, I will add a qualifier here. And again, Dr. T's opinions are in their own weight category.
Their own category.
Yeah, compared to Dr. Victory. But
Yeah.
what I will say that is, if it will stress you out and make you ultra paranoid the whole time, don't do it.
I would support that. Yeah, I agree with that. That's a very valid add-on. Yep, valid comment.
For what it's worth, I learned it from you.
There you go.
This isn't my own theory. You know what I mean?
That's a valid comment. Yeah,
right?
I mean,
like if you could go and you're relaxing, got your feet up and you're eating and caviar's flying all over the place and life is good, okay.
Sure.
But if you're going to get stressed out and panic and, because I heard that in America now the, what is it? TFSA? That's what they say, right? Like
TSA.
TSA, like it's just complete chaos is what I hear.
It is, yeah.
So if you're going to get stressed out, don't do it.
Different story.
Different story.
Sure. Yep.
Dr. T. See, I earned that title, guys. Okay. Can I do my transfer without the PIO shot and just go to the progesterone orally or vaginally? My last time using PIO, I had a very hard time, and now I have nerve damage.
Yeah, you can. It's not as effective, but you could use a combination of oral and vaginal. Sure.
I'm afraid to poop on transfer day.
What?
Yeah, that's what somebody said.
I'm afraid to poop on like after the transfer.
Mm-hmm.
No, you're not going to push out an embryo because you have to strain to have a bowel movement. Yeah. You know that whole story about women that defecate during delivering a baby? That was like, that went crazy. I think it's over 100,000 views now, right? It's huge. And huge on TikTok too.
On TikTok.
And all these opinions too. Like a whole bunch of Europeans were like, they make us take like an enema or whatever.
Yeah.
And we're supposed to clear out our bowels. And I was like, what? I can't believe. And I mean, hey, and some of them were like, no, we want that. And then I was like, really? Like, it's so natural. Like, just whatever needs to happen, let it happen. But it was really controversial. I didn't think that'd be a controversial topic at all.
I actually thought it'd be a topic that people would be like, they don't want to deal with.
Yeah.
But it was a complete opposite.
Yeah.
When we created that and we had the title "Poop" in the title, I just looked at it for like 10 minutes and I was thinking to myself, is that really the best word to use here? Like, is that really going to get, like, do people care about that?
They care.
They care.
Yeah.
Yeah. Conclusion is they really care.
So don't worry about defecating during your day of embryo transfer. It's not going to harm anything.
Don't worry about anything. When you're in the hands of Dr. Victory, everything's going to be all right.
I don't know about that, but thank you.
This might be a dumb question. No. I ask those all the time. Don't worry. You go ahead. What do you mean when you say medicated versus unmedicated cycles?
Yeah. So medicated is a hormone replacement. So take a whole bunch of estrogen, which is often very high doses, and then take progesterone and then do the embryo transfer. Now, we do end up using estrogen in some of our cycles when we have to thicken the lining because it's not responding to letrozole. But we're using like minimal doses, which is very different than 2 to 4 milligrams 3 times a day. That's a very high dose of estrogen.
Hi.
Hello.
After endosurgery, how long to wait before doing the microbiome testing with Fertility? Is the first cycle okay, or would microbiome be off due to surgery?
As long as they didn't go in your uterus, it shouldn't be off. So I would think first cycle would be okay. There are some associations between endometriosis and your microbiome. So you may want to give it an extra month to kind of settle down and see where it lands. But it would not be unreasonable to do it immediately.
Dr. Victory, I'm your patient from last year.
Okay.
First transfer, I became pregnant. Baby ended up having CHD. So you had to transfer me to London.
Right.
I just wanted to say thank you. Our baby is thriving at 9 months old, CDH survivor. You were the person who had to tell me the diagnosis.
Oh, well, thank you for saying that. That's very sweet and kind. Appreciate that. And I'm glad your baby's doing well. And I know exactly who that is.
Hi, King and Dr. V.
You like that? Yeah.
Maybe I should come in with one of those Burger King crowns and just really act it out. What is the protocol called? Lupron, letrozole for 5 days, estradiol, PIO, and progesterone suppositories.
Well, we don't use estrogen unless we need it, but that's a modified natural or a letrozole cycle.
Hi, Dr. V. Have you had successful IVM cycles end in pregnancy? Why are you trialing this in an older population? Are women in their 30s eligible?
Women in their 30s are eligible. We're trialing it in the older population because the whole idea is that the egg quality is diminished because of oxygen concentration. And so if you actually get the eggs early and mature them in the lab, you may actually have a higher success rate. There's a recent publication on something called a highly individualized egg retrieval protocol. And it was the same author that actually sort of was the catalyst for me to go into the IVM study that we're doing. And in that study, they actually demonstrated a pretty high success rate in women with really, really advanced age. They're getting like a 13% live birth rate in women who are like over, 43. So that's very, very, very good. especially when you consider some of their patients are like 45, 48. And so we're really trying to capitalize on the idea that if we expose the eggs to higher concentrations of oxygen, those eggs will do better. Now, the interesting thing with it is that we are actually seeing phenomenal egg quality. So it does work. There's no question. I will tell you that the retrievals are a nightmare because they're very difficult for me. The patients are asleep, they're comfortable, but they are very difficult to get the eggs because normally I'm going into a follicle like this, and now I'm going into a follicle that's so small you can barely see it. So it's very hard to get the needle right in there, and then you got to twist it around a lot to kind of curettage the follicle to get the eggs out. We are not at this stage yet because it's very early in the study where we've done enough cases to actually say that we've gotten even to the transfer stage, but it is starting to show some promise. I will say that. And we actually have 2 cases right now that we are waiting for embryos on, and I'm very excited to see what those show. So I'll let you guys know after we've done kind of 50 cases or so. I think that's when we can turn around and say, okay, here's what we're getting.
Hi, bromance. Can you do a modified natural after Lupron suppression?
Yeah, we do it all the time. We use Lupron and then we do letrozole. It may not work if you use the Lupron suppression. So we do cycle day 21 Lupron and then we do our letrozole, but it may not work if you do a Lupron suppression. Like if you do 3 months and then you only take letrozole, it may not be enough to wake up the ovaries.
Dr. Victory, this question is for you, I'm going to say.
Okay.
Many think natural or modified natural means ovulatory.
Yep.
You need to define your endo protocol as non-ovulatory, low or no estrogen. Everyone in my groups are confused on your protocol because they think it's medicated.
Yeah, I addressed that in a whole bunch of the posts where people commented on that. So it is a modified version of a natural protocol. It's letrozole based, and there's no question that we occasionally use some estrogen, but a medicated cycle is high doses of estrogen. We are not using high doses of estrogen. And natural cycle can be with ovulation or without ovulation. So there's all sorts of different types. I'm not too concerned about the semantics of it. The reality is we use letrozole because it's been proven to have the highest success, lowest risk of miscarriage. And we occasionally will use estrogen for the patients who aren't thickening. Our endo protocol is totally different because you have to be suppressed first. So that's a totally, totally different beast altogether.
We need more likes, ladies and gentlemen. More likes. I want more likes. We're having a good show. We're having a good time. Dr. Victory, sip tea with all of us. Show some love. Show some love. Power Duo. Are donor eggs my only option? You ready? Get ready for this.
Okay.
Some info here. I'm 39.
Yeah.
4 implantation failures, 1 chemical, 2 3-day embryos each, new clinic, 2 retrievals, 7 fertilized, 6 arrested at day 4, 1 aneuploid, sperm frag 16.8.
I'm certainly not going to say donor egg is your only option. I think there are a variety of options. I'd need to know your history better in order to understand how to respond to that. You may be eligible for a natural cycle. You may be better with a mini stim. You might be a good candidate for IVM, or yeah, you may need donor eggs. I would need to know more details before I'd be able to commit to something there.
Dr. Victory, I am struggling to decide between vaginal and scheduled cesarean. 40 years old, IVF due to SMBC, modified natural transfer, 30.5 weeks with no complications, but I have LS. Specialist says no narrowing and elasticity looks good. Used to tear with intercourse pre-treatment. Haven't tried since. OB is leaning to cesarean due to LS. I think I want to labor and switch to section if forceps vacuum.
Without seeing you, it'd be really hard to answer that. For those in the audience that don't know what LS is, it's lichen sclerosis, an autoimmune condition which causes skin changes in the vulva and architectural loss. That skin doesn't heal as well as normal vaginal tissue will. So I would need to see you to answer. Have I done a cesarean section for patients like that? Yes. Have I let patients deliver naturally? Absolutely. I would welcome a robust discussion with you and then let you make your own choice as to how you want it to proceed.
Sending big love from baby Brownie and her adoring grateful mama.
Hi, Heather. Love you. Miss your brownies.
Should someone who has an isthmusal repair have their uterine lining check before they're trying for a VBAC?
Yes, absolutely. They should. 100% they should, because it could still thin out, especially depending on the quality of the repair. And it depends on how you had it repaired. Sometimes we just resect, which further thins the uterus. So you need to be cautious with that one.
I'm trying to figure out what this introduction is. I just can't. S/O. Do you know what's S/O?
No.
S/O doc. S/O doc exclamation exclamation.
S/O.
S/O.
I don't know. Go ahead.
I don't know.
Let's ask.
Well, thanks for the S/O.
Yeah, I'm not sure what that means.
We don't know what that means.
If anyone knows what S/O means, tell us.
Yeah, everyone else tell us. Would love your guidance for my situation. Background 38, trying to conceive 3 years, one chemical, PCOS, high AMH, 6.48 nanograms per mil,
Woo.
and high androstenedione.
Androstenedione. Okay.
Androstenedione.
Sure.
Partner
Yeah.
is normal. Do I have good IVF odds?
Well, you got strong ovaries.
Shout out. Shout out.
Oh, shout out.
Shout
There you
out. Shout out. Everyone's saying shout out, shout out. Shout out.
go. Yeah, you've got strong ovaries, so your chances would be excellent. I mean, it would depend on many other features, but that's the basis for how we do. So from that perspective, you're very good.
Shout out. It's in my head now. How did we miss that? Anyway, I'm in the fertility mind now, guys. I am doctoring right now. We have high sperm DNA frag.
Okay.
Due to an obstructive issue, a cyst in the urethra. Would it be necessary to choose a clinic that uses Zymo devices during IVF, or is the swim up method fine?
No, swim up is not as effective as Zymet for doing a reduction in sperm DNA fragmentation. If your partner can ejaculate twice on the same day, 3 hours apart, that reduces it by 80% by itself. Make sure you're doing all the things ahead of time you need to do to improve the outcomes, and then go from there.
Shout out. Don't know how we guessed that. Hey, so we did a 5AA transfer yesterday. Lining looking great. Did we?
Yeah. Didn't we? 5AA?
Just showed up.
Okay.
Super nervous. Any advice?
Oh, no, we didn't do that one. Super nervous. Don't be nervous. It reduces your chances of success. Be calm. Whatever's going to happen is going to happen. You can't change it now. So stay positive, stay hopeful, live in the moment, enjoy yourself, do things that you love to do, find some ways to do calming stuff, meditation, prayer, yoga, whatever you want, but don't panic because that's not going to help.
I am trying to find the starting for this. Not having an easy time here. Okay. Can you touch on rapamycin and taking it before an egg retrieval? My doctor wants to put me on this.
Yeah. So there was a recent study which showed that rapamycin was beneficial for patients with diminished ovarian reserve in terms of improving their IVF outcomes. And there are a couple of studies looking at it for endometriosis patients. So many of us use it. I've been using it for a while now.
Dr. Victory, happy Tuesday, Dr. V and Mr. T. For women with low ovarian reserve who are advised to start CoQ10 to help with egg quality, what dose and is there a specific brand you recommend? And how long should you take it for the best benefit?
So studies show that the best benefit is actually 6 months, which is a very long time. But from the standpoint of dose, it's usually 600 milligrams per day. And as a Canadian, we are not allowed to support one product over another. So I don't support one brand over another.
Oh, this read was so good on that other doctor. That's why you are the great one. Hello. I took Dynagest for 10 days in preparation.
Okay. I've never heard of that before, but sure.
You've heard of Dynagest?
No, I've never heard of someone doing it
take
for 10 days.
Yeah, me neither, for what it's worth. First time I heard about it.
Okay.
For a hysteroscope polymectomy. That's why they took it.
Okay.
Right. It has been 13 weeks to stopping Dynagest, but no ovulation and cycle coming every 2 weeks. Any suggestions to restore ovulation?
That whole story is so confusing for me. Can you DM me so I can figure this out with you? I have no idea what's going on there. That doesn't make sense. I would need to know what your cycles were like before. What's your AMH? What are your hormones? What's your thyroid doing? Like, you need to go talk to your doctor. I'm clearly not your doctor because I've never done that before in my life, but you should go talk to your doctor and figure out what is going on. But easily determined by a saline infusion, sonohystogram, and some hormone tests.
Hello to you both. Thank you for always taking the time to educate us on different topics. It helps to make me feel more comfortable as a patient at the clinic. Do you know how soon clients could hear about funded cycles? Thanks again for all you do.
We have loads of funding. Anytime you want, just start. If you're a patient that wants a funded IVF cycle, just call and say, I want to start my IVF soon, and they will get you in.
Thoughts on getting pregnant 10 months after a C-section?
Means you need an automatic repeat C-section, but aside from that, it's fine.
Is there a certain time where you don't get a C-section after you had a C-section, or is it forever a C-section?
No. It's totally fine to do what's called a TOLAC, a trial of labor after cesarean, or it used to be called a VBAC, a vaginal birth after cesarean. As long as the uterus was closed properly the first time, it wasn't cut up and down. It was cut side to side. And there are no other contraindications like placenta previa, stuff like that. So no, it's totally reasonable to have a vaginal birth for people that want it. No, there's only some contraindications to it.
Hi, Dr. Victory. I love your lives.
Oh, good. Thank you.
Am I not here? Am I chump changed? I had a chemical.
It was a plural your.
I love your lives.
It's a plural your.
Your is a plural?
I'm trying to help
part of
you.
the your?
I'm trying to help you feel better.
I went from King T, his excellency, to
your lives.
Your lives.
All right.
Well, your lives. I had a chemical in January. I'm 38, high AMH, 6.48.
We did that one.
Oh, we did that one?
Yeah.
Can't believe I heard it twice.
Yeah.
Hey, doctors. I did my microbiome test and it came back step B. Is there a treatment?
Oh, strep B?
I assume.
Okay.
It's step, STEP, but
okay,
it's a typo.
Probably
that can happen.
strep B, yeah,
for sure.
Yeah.
Is there a treatment for it other than antibiotics? I've had 5 failed implantations.
You can try probiotics, naturopathy, biofilm breakers. There's ways to do it without antibiotics. Yes, the naturopaths are much better at managing that than we are.
Is that right?
Oh, way better.
Really?
100%. We're idiots compared to them for microbiome.
For microbiome.
100%.
Oh, interesting.
Happy to admit that. I got our protocols from our naturopath.
That's the way to do it.
Yeah, they're great.
See that, guys?
Holistic healthcare is always better.
See that? Not figure. Give credit where credit is due.
Give credit.
Fair man. See, he does the research. He figures it out. He's not just blasting for no reason. You know who I'm talking.
Yeah.
Hello. What is your recommended FET protocol for PCOS and infrequent ovulation? I prefer natural cycle, but I only ovulate very 2 to 3 months. Normal BMI and no insulin resistance for 2-hour insulin test.
So she just wants to know how to ovulate, and you don't want to use any meds, inositol, NAC, resveratrol, ALA, coenzyme Q10. Those might help, but ultimately it's important you ovulate because it's a risk factor. If you're only ovulating once every 3 months, that's a risk factor for estrogen dependent cancers. And so I would prefer to just put you on letrozole for 5 days a month, but you'd have to be agreeable and we'd have to have a discussion.
My doctor is wanting to do Lupron before an ER. This makes me nervous. Thoughts? I only have one ovary.
Proven to be detrimental.
Really?
Yeah. Proven to reduce your success rates, reduce your egg yield. So I would not advocate for that. There's lots of studies on that.
It's another surprise. What is your opinion on an antihistamine protocol used in conjunction with a modified natural FET?
There's absolutely zero evidence to support the antihistamine protocol. Zero. We're running a randomized controlled trial, and we had to pause for a little bit, but now we're doing it again. There is no evidence aside from our trial that there is a benefit to doing a antihistamine protocol. Zero. Not a single study.
Crazy.
Yeah.
Because that's all over the internet. That's just like one of those. Like,
yeah,
internet-
people are using Benadryl and Pepcid, so it's an H1 and an H2 blocker, and they're all thinking that this is like a thing, but there's literally not one study out there. Nothing. There's zero. I don't even know who came up with it.
Is there even common sense on how it could work? Like, what is the background theory?
Not good common sense. So the idea is that you're reducing inflammation via like histamine release, which does cause a lot of inflammation. But no.
So they think it's an allergy problem.
An inflammatory problem from a response that is allergically mediated.
Yeah.
Yes.
Interesting.
Yeah.
I don't think that works, but hey.
No evidence yet.
No evidence yet.
Yeah.
Hello, Dr. V.
That's me.
It's not me, so skipping that question. No, just joking. Are you familiar with Dr. Kilman's endometrial function test, Yale? Our REI suggested my wife to do it because she's had 4 failed FETs, all embryos non-PGT tested, age 34 at the age of ER.
I am familiar with it. I don't use it. I don't believe there's sufficient proof to support it, but at the moment, there are no good tests for endometrial receptivity, so I don't do any of them. I do microbiome testing, which I think is hugely valuable, but I am not doing the endometrial function tests, ERA, what's the French named one? Matrice. I just don't see any benefit to those.
See, the people on TikTok, they're figuring it out. My kings. Yes, we are all listening now. You have our attention. What are the pros and cons transferring 2 euploid embryos?
Pros, 7% increase in success. Cons, drastically higher rate of twins, higher rate of complications associated with twins, more rapid loss of your embryo number if it doesn't work, and overall equivalent success rates. So if you sequentially transfer the embryos 1 at a time versus 2 at a time, you actually end up with the same success rate ultimately. And it's way safer doing it 1 at a time.
How long should you take probiotics before an FET and both capsules and suppositories?
As long as possible.
There you go. Hi, just starting our journey consult at the end of the month, 35, trying to conceive, 10 months, 1 chemical, suspected endometrioma via MRI, count motility good, 3% morphology, recommendations.
Improve the sperm, start taking supplements for the endo, and then we'll do the consult and we'll figure out how we have to help you.
Dr. Victory, I am 30 years old. My AMH is 8.5 picomoles and FSH 12.5. My TSH came back 2.4. My periods are only lasting 3 days. Is IVF the best approach for me? What protocol works best for this?
What was the AMH?
AMH 8.5 picomoles.
IVF is the best from a success standpoint. Sure. I mean, it's always the case. IVF is a higher success than any other version of anything. Even if you're totally fertile, you'll have a higher success with IVF than you will natural, but it's not your only option. There are many other options. You could try natural, you could try IUI, you could try IVF, you may want to do surgery. It depends on what's wrong. How did we lose our camera? Dead battery? That would be bad.
No problem. No problem. Hang tight. Hang tight. I don't know what.
You want me to squeeze in beside you?
No, don't worry. We'll get it. You're here now. That's for a few
All right.
minutes. They can see you. Look at that handsome smile. Wow. All right. Next question, Dr. V.
Yeah.
In your opinion, who is the better doctor? Dr. V or Dr. T? We joke. I'm just buying a couple seconds here. Okay. And I can just obviously raise this one for less tension.
There you go.
There you go. All right. Forget that. Okay. Goats.
Yeah.
I have a second Dr. V consult, April 19th.
Okay.
We're doing retrievals with Dr. V in May. I have call with Nurse Angelica this Thursday.
Okay.
Can I get started on ripamycin now? You said on first
No.
consult I need for 8 weeks.
No. Oh, sorry. Prior to retrieval? Yes. Yeah, you could if you're aiming for May. Yeah. Contact the clinic tomorrow and explain, and then we'll go from there.
Really low. It's a fast charger. What is more important, the grade of the embryo or a PGT normal rated embryo?
Oh God, PGT normal for sure. Yeah, absolutely PGT normal.
3 years TTC, one chemical, 38 years old, high AMH, 6.48 nanograms per mil, PCOS, partner DNA.
We did that one.
Oh, we did that one?
Yeah.
Okay. High Kings,
Okay.
not plural. that means me. Pick me. Well, I just did. Of course I'll pick you. Pick you all day. How soon do you start estradiol after 60 days suppression? I haven't even started the protocol yet, and I'm already counting down to when Haley tells me I can slap a patch on.
We don't unless we need it. So it's all dependent on how the patient is doing. Yeah.
Oh, this one I'm definitely going to read. Hi, oh so handsome T and V. Flushing.
Yeah.
I have a cold and had a low grade fever for half a day. I'm due to start stims in 2 weeks. Would you recommend postponing stims longer than this? Thanks.
Yes. There's a study Tarek and I reviewed a year or two ago where we looked at the systemic inflammatory index, SII. And actually, a patient just asked me for it online, and I pulled it up and sent it to her the other day. And that study broke your SII into quartiles, like, you know, if you're in the bottom 25%, 25 to 50, 50 to 75, and so on. And they looked at the outcomes, and there was a huge difference. So if you have inflammation, your chances of success are way lower. So don't do IVF when you're inflamed.
We'll end it on this one.
Okay. Oh, what time is it? It's 9 o'clock.
9 o'clock.
Okay.
You feeling
Yeah.
good? Or
Yeah, I'm good.
okay. Is coconut oil bad to use as lube?
Any of the oils are not as safe as using a sperm safe lube like pre-seed. Yeah.
That's it. I was hoping you can go with that a little bit.
No.
All right, we'll do one
Plus-
more. That
plus
was such a weak answer.
Plus, it's smelly.
Let me just a random TikTok.
Okay.
If they have a good intro, they got it. Yo docs. No, we're not going to answer yo docs. Sorry. I read it, but we're looking for something. Well, it seems unfair now that I'm scrolling so long looking for a good intro.
Just ask.
There's so many.
Just ask.
I'm just endlessly scrolling here. It's insane. Okay, guys, hold on. Let me just go to the most recent one. Just really cherry picking. Please, says this one lady. Please what? What if my inositol doesn't help improve irregular cycles at the age of 26? All my levels are fine.
Letrozole. That's too easy.
Okay, another one. Another one. We can't stop. We're trying to help you guys out. We want to help you guys. What can we say? We'll take it from Instagram. Last but not least, on Instagram, here we go. Ladies and gentlemen, the final question of the day. Do you suggest a microbiome test for patients who have never done a transfer yet?
Only if you have a very limited number of embryos and they were very difficult to obtain. In that case, yes. If you have enough and you don't need to worry about the potential loss of one, not that every embryo isn't sacred, they are, but there are costs and time lags and stuff like that associated with microbiome testing. So it's not something we kind of push on everybody. I think everyone should know about it. Everyone has the option to do it, but I'm not advising people to go do microbiome if they've never done a transfer before. It's usually reserved for failures.
Is that it?
I think so. Call it?
Call it.
Okay. Thank you, everybody, for watching the show. I think next week I will, I don't know. I'll review something cool next week. We'll do an article next week.
All right. We got a big article coming.
And thank you for letting me vent. And to the people who are having communication issues with VRC, that's not okay with me. So maybe the whole group can DM me. And I will come on for the group and we can have a group session on Zoom and figure out what's going on. I'm happy to do that. So DM me or have one of the representatives from the group DM me. Have a wonderful night, everybody. And we'll see you next week on Fertility Fact or Fiction.